So, on behalf of EuroELSO, it's a great pleasure to welcome all of our participants from virtually all over the world today. And we have the chance to talk to colleagues in London, UK, who have been on the front line with COVID for many weeks now and to have extensive experience. All the three of them, of our experts, work at the Guy's and St. Thomas Hospital. And we have two blocks on hyperinflammation and coagulatory problems on ECMO. And the first block will be covered by Sangita Agarwal. Nina is a rheumatologist at the hospital, and together with Boris Lums, who is the intensivist in that team, they cover the lung inflammation service for critically ill patients. And obviously, they will cover the topic hyperinflammation. And then in the second presentation, we have Andrew Retter, who is not only an intensivist, but has a dual certification also as a hematologist. So naturally, he's really into hemostatic issues in critically ill, and in this case, ECMO patients. Guys, it's we are tremendously thankful that you are taking the time, even though being so busy. And maybe you can want to introduce just 2 or 3 words how you've been doing those last days and how the things have been changing before we start with the first presentation by Nina and Boris.
Hi, Peter. Hi, everybody. Well, it's all sort of quietening down, we hope. I think we've only got about sort of 20 or 30 still on ICU. I think in total, we've had about 320 through critical care, 52, 53 on ECMO. So it's certainly been busy.
Yeah, I absolutely echo what Boris has just said there. We'll show some slides about our activity a little bit later, but it appears to be, fingers crossed, calming down now, which is good. There's patients in the latter stages of their illness working through, but it has been exceptionally busy. I think lots for all of us to learn. It's a pleasure to speak to you all today.
Okay, well, thank you so much. Much appreciated that you share. Now, before we set up your presentation, just for our participants, during all of the time, you may enter questions in the webinar tool, which I will pass on during the last part of our webinar, during the discussion session to our experts, so we can discuss all of your questions properly. If you come in late, everything will be recorded and ready to be downloaded at the EuroELSO website within the next 1 or 2 days. And now it's a very special pleasure again to have all the 3 of you, and we will start with Nina and Boris on the hyperinflammation part. There you go.
So thanks, Peter. Can you see my screen?
Yeah, I can.
I can't see my presentation.
We can see it.
You can see it there.
Okay, can you see it still?
Yes.
Excellent. So thank you very much for inviting us. I'm going to start off just as a background on our sort of day jobs. I'm in respiratory and a little bit of critical care. Nina is a rheumatologist and a physician, and together we've formed the lung inflammation service, which has been running for about 10 years. And that is itself embedded within the St. Thomas's Severe Respiratory Failure Service, which hosts our ECMO service. And you may ask the question, why have a chest physician and a rheumatologist embedded within a severe respiratory failure service? Well, the answer to that is because we believe that ARDS is not one disease, but many. And some have an obvious cause, being run over by a bus or having diffuse meningococcal sepsis, but others don't. And in those cases of ARDS which don't have an obvious cause, we believe that there may be a subset who have hyperinflammation, be that in the whole body or be that simply in the lungs. And we believe that if we can immunomodulate those with hyperinflammation, we can improve outcomes. So that's our background. That's what we've been doing for the past 10 years. And so the next question is, what's all this got to do with COVID? Well, we think that severe COVID may represent itself a hyperinflammatory state, and that because of that, immunomodulation may be of benefit in COVID. So I'm just going to hand over to Nina, who's just going to run through COVID and some aspects of hyperinflammation.
Thanks very much, Bea. So a unique opportunity, I think, in all of our professional lives to study a new condition and its impact in such a way. But I suppose as many people now appreciate and understand, it seems to be a disease that is marked by heterogeneity. The early stages seem to be characterized by lymphocytic viral pneumonitis, but the second or later stages seem to be characterized more by a dysregulated host immune response, i.e. the interaction of our own immune system with the virus itself. And there's some evidence, obviously, to support that with increased markers of inflammation, such as IL-6 levels and ferritin. And ferritin and IL-6 levels in particular have been shown to be predictors of mortality, in addition to, for example, CRP, lymphopenia, and LDH. And as you can see here, a mean of 1,300 in non-survivors versus a lower level of just over 600 So we think that COVID-19 causes hyperinflammation, and how that represents in patients is with a persistent respiratory failure. Often the patients will have fevers in the absence of infection, and they'll indeed have elevated inflammatory markers such as CRP and ferritin. Now, in some of those patients, this severe systemic inflammation may lead to multi-organ failure, and it's led to many of the features that we associate with other conditions, such as secondary hemophagocytic lymphohistiocytosis or secondary HLH, and cytokine release syndrome. And these have been talked about widely in COVID-19. And actually, they probably represent a family of conditions that are characterized by cytokine-driven hyperinflammation. So, for example, the activation of macrophages that then release pro-inflammatory cytokines that then cause widespread cellular damage, tissue injury. And we know that in secondary HLH, a common cause for this is viruses. Malignancy, particularly lymphoma, can be associated with secondary HLH, in addition to other rheumatic diseases, such as, for example, Still's disease, adult onset Still's disease, and lupus can also be associated with a secondary HLH, in which case the term mass or macrophage activation syndrome is then used. There are similarities, again, with cytokine release syndromes, with these very hyperinflammatory phenotypes. We see a similar cytokine profile in COVID-19. So without doubt, there seem to be similarities across these hyperinflammatory syndromes that we are seeing. Now, just also to mention another hypothesis that seems to be gaining traction, and that's the role of the endothelium or the vascular. It may well be that this cell type has a strategic role. Certainly, the pulmonary endothelial cells may be key, and the associated injury and dysfunction may lead to a breach in the vascular barrier, leading to tissue edema, and endotheliitis, activation of coagulation pathways and thrombosis, and deregulated inflammatory cell infiltrate and tissue injury that we are seeing. And certainly this may account for some of the immunothrombosis that we are seeing in a number of vascular beds. So perhaps what we will look back and see is this severe endothelial distress syndrome almost that seems to be unique or common to COVID-19. So what does that actually look like in practice? What do these patients actually, how do they behave and how do they seem? So this is a retrieval from one of our own units. So this is a 35-year-old gentleman who, as is often the case, was managed at his local hospital. Interestingly, he had at least a 7 to 10 day history with marked fevers, so reaching 41.5 degrees with an increasing oxygen requirement. And that actually fairly rapidly seemed to develop multi-organ failure and a new pressor requirement. So he was referred up to our centre, and this is his admission data. So just to note the time frame, so he clearly hypotensive despite his vasopressor requirement there. And I'm going to show you some of his lab data. So renal impairment, as we commonly see, an elevated LDH, a CRP of 277, and a PCT, if you can just see there, of greater than 100. And I'm just going to come back to that in a moment. And also a degree of cardiac injury you can see there with his BNP. So this is just giving you a sense of the intense CRP-emia that he had in the context of a marked hyperferritinemia. So levels here of 7,000, which really are very high. Now, this is his course, and we felt that he was indeed one of those patients with a secondary HLH, secondary to COVID. So we treated him with intravenous methylprednisolone, 1 milligram per kilogram BD, so the standard Majuri dosing, in addition to IVIG, so intravenous immunoglobulin at a replacement dose of 2 grams per kilogram, and anakinra, which is an IL-1 blocker, given the severity of his presentation and the features that he has of HLH. And if you can see here, this is his sweep flow. And again, just to note the days. So he comes to us late on the 31st of the 3rd, and his sweep flow is 6. And then over the next 5 days, it comes down very rapidly, and he's decannulated on the 5th of April. This is his lab data just to mirror his treatment response. So again, that initial marked hyperferritinemia and CRP-emia, and the rapid fall with immunomodulation down to near normal levels. Now his PCT, you can see here, and as I mentioned, was greater than 100 when he first presented. Now, indeed, as is sometimes the case, he had no features of secondary bacterial infection. But sometimes PCT can be an inflammatory marker of immune activation. And in his case, we think that's exactly what it was showing. And it stayed at greater than 100 and then very slowly fell down. Again, so PCT sometimes is a marker of immune activation as opposed to intercurrent infection itself. So lastly, just to raise this new presentation that we are now seeing both across the globe, really, of PMISTS, so the pediatric presentation that you may well be aware of. To date, around 230 cases presenting with hyperinflammatory shock, features of Kawasaki toxic shock, and this intense macrophage activation. Interestingly, present with fever, gastrointestinal symptoms, sometimes a rash, and cardiac involvement, in addition to coronary artery aneurysms. But their PCR testing is usually or maybe positive or negative, but interestingly, they are all IgG positive, which raises the hypothesis of this being an antibody-dependent enhancement effect, i.e. not high enough to confer protection, but high enough to allow viral entry. Really, just the reason I'm mentioning is that we have already in the past 10 days seen 2 adults, young adults, that have presented with exactly the same phenotype, both of them PCR negative, both of them IgG positive. We use our standard COVID-19 immunomodulation inductions, so pulse methylprednisolone in addition to immunoglobulin and anakinra. We screen them for coronary artery aneurysms. They do very, very well with this approach. But really, just to note this newer presentation in adults of this pediatric phenotype.
So that's all fine. So we think that we can treat the COVID hyperinflammation, perhaps treat the COVID HLH, and perhaps treat the multi-organ dysfunction and the cardiac dysfunction. But of course, the majority of patients with COVID do not die of multi-organ failure. They die of lung failure. And so we then have to look at that lung failure and ask, is the lung failure in COVID just a normal ARDS? And of course, technically, yes, it is ARDS because they've got bilateral infiltrates, they've got a low PF ratio, and it's not cardiac normally. But the imaging of patients with COVID lung disease does not look like normal ARDS. This, I think, is normal ARDS. This is I think a streptococcal pneumonia with shock, and there is bilateral infiltrates, and they're worse at the bases than at the top. Sorry. This is that person's CT, and it's a classic normal ARDS, black at the front, white at the bottom, with a little bit of grayness. Sorry, in the middle. So that's sort of normal ARDS. If you look at COVID, the radiology is different. It's different even from, you know, flu. It's a completely different pattern, and it's characterized by bilateral peripheral infiltrates, which appear sort of lumpy and hug the edge. And there's almost a sparing of the bases. And here it is on CT. So again, it's peripheral, it's lumpy, it's areas of consolidation, hugging the periphery, but with also a degree of sparing of the bases. And it lacks that gradient from front to back. And it's difficult to see just on these few cuts, but there are other areas of sparing. So this black area is an area of sparing. And here's another area of sparing. And these are probably areas of spared secondary pulmonary lobules. So if you took this CT to an interstitial lung disease group, and we work in one, and said, what is this? They would say, well, that's an organizing pneumonia pattern disease, because that's what it is. It's peripheral, it's consolidation, and it spares the secondary pulmonary lobules. And then we said, well, is it? Well, we've got some data from histopath. This is from our hospital, courtesy of Dr. Ula Mahadeva and Anna Green. This was a person who was on ECMO for about 5 or 6 days, then died principally of brain failure, but whose lungs weren't good either. I won't go through the detail of all of this because I don't really understand it fully, but in the alveolar spaces, there are buds of granulation tissue and fibroblasts. You can see them on Masson's trichrome and also on the elastic stain. And oddly, these are called Masson bodies, and they are the hallmark of organizing pneumonia. So that's one of our cases. I mean, there's other stuff going on. There's a bit of DAD and there's a bit of other stuff, but there's a lot of organizing pneumonia. If you look at this group from France, this is 6 postmortems from COVID. In one of them, there was a viral pneumonitis. The other 5 all had pictures of organizing pneumonia, and in some cases progressing to a fibrotic organizing pneumonia. And you can see again here are the Masson bodies with the granulation tissue within the alveolar spaces. So the CT appearances in the histopath suggest that COVID damaged the lung through an organizing pneumonia progressing to a fibrotic organizing pneumonia pattern, rather than a normal diffuse alveolar damage or ARDS process. And you may say, well, so what? But the interesting thing is that organizing pneumonia is one of the interstitial lung diseases, and it is characterized by being markedly responsive to immunomodulation. And so our hypothesis is, well, COVID pneumonitis looks like an organized pneumonia, and thus itself might be susceptible to immunomodulation, whether or not it presents with concomitant HLH or a hyperinflammatory state or with cardiac involvement. So Nina's just going to go through some of the evidence for that.
So thank you, B. So to date, the clear role of immunomodulation in COVID-19 is unknown, but what can we take from some of the other experiences in perhaps other coronaviruses, or indeed in ours as a whole? Well, the first thing is obviously the role of steroids. So there's certainly a signal of benefit from the Majuri data, and actually a survival benefit if you read the literature in SARS. And I think an important point is that SARS is not dissimilar to COVID-19. Indeed, COVID-19 is very similar to SARS in many ways. And certainly a significant element of the morbidity in SARS was thought to be secondary to a cytokine release syndrome. So there are a number of similarities, and I think lessons that we can learn. And certainly from the registry data, there is a survival benefit from the use of moderate doses of steroids. So in COVID-19, the early data with respect to steroids, as you can see here, 26 patients treated with intravenous methylprednisolone at 1 to 2 milligrams per kilogram per day for 5 to 7 days versus a control with reducing oxygen requirements, as you can see there. And then more recently, actually, a nice paper from the States, 132 patients, again, I think using moderate dose steroids, and I would emphasize actually, and early on. So 0.5 to 1 milligrams per kilogram for 3 days versus 81 patients who received standard of care. And certainly they used a composite endpoint actually of escalation of care, new mechanical ventilation and mortality rate. The differences that you can see, so 34.9% versus 54.3%. So certainly I think steroids may well have a role. I think the timing is key, and the dosing and the taper, again, I think are key. Some of the other drugs, and tocilizumab, which is an IL-6 receptor antagonist, has received a lot of interest. Early data from the Italians and the Chinese, you can see there. Just a note to say that I don't think using CRP as an endpoint in tocilizumab is necessarily helpful, because of course that's one of the things that it will cause, and that just confirms that the patient has received the drug. But certainly 21 patients that received tocilizumab in an open label Chinese study seem to do relatively well, with 75% having falling oxygen requirements, and 19 patients, i.e. 90% improvement in their imaging with discharge home. Anakinra. So anakinra is a very interesting drug, IL-1 alpha and beta receptor antagonist. There is a survival benefit, again, in inflammatory ARDS from the data without an increased toxicity signal. And it has a track record both in HLH, so for example, macrophage activation syndrome, and tocilizumab refractory CRS. There are currently 10 trials in COVID with the use of anakinra. And indeed, I think this has probably been a time where all of us have seen trials come online very, very quickly, and they range from the usual candidate interventions through to, actually, interestingly, the alpha blockers, which have just come online in the States.
Thanks. So our sort of approach is to enroll anybody we can into a trial. But of course, when we first started, some of the trials weren't up and running, and there are patients who are not eligible. So our experience is, as I said right at the beginning, we've seen 50 plus ECMO-dependent COVIDs and over 300 ventilated COVIDs. I just want to go through 2 ECMO-dependent ones and a couple of ventilator-dependent ones. They're all in their 40s or 50s and previously well apart from a bit of diabetes or hypertension. This is a bit of a busy slide. There's a screen dump from our clinical manager, and along the top is the day. So these are columns of the day. So that's the 4th of April, the 5th of April, the 8th of April, and over here to the 19th of April. And then down at the bottom, it goes on to the 20th, 21st, 22nd, 23rd, and 24th. The important thing is here's a sweep flow. These are all, this person was on VV ECMO. And you can see they're relatively ECMO dependent. So on the 4th of April, it was sweep flow was 4. 8th of April, it was 8, sorry. And then going on to the 16th of April, it's 7.5. And then the 20th, the 21st, the 22nd, the 23rd, and 24th of April is stuck on a sweep flow of 7. So really stuck on ECMO for about 3 weeks. Here's a CRP, so the CRP goes up, the CRP goes down, but it never really settles much below 150. So pretty inflammatory. And with that, a ferritin, which starts off high, comes down a little bit, and then goes back up again. So intensely inflammatory and stuck on ECMO. So he was treated with some methylprednisolone. The methylprednisolone goes in, sorry, skipping. Methylprednisolone goes on the 24th of April. So I'm trying to point that out without advancing the slide. And with that, there's a rapid fall in the CRP. There's a little blip here at the end of that. And that's followed by a fall in the ferritin. What I think is more dramatic is the response as far as his sweep flow is concerned. So here we are. Remember, we're at 3 weeks of a sweep flow of 7. In goes the methylprednisolone. You can see the sweep flow falls, and these are daily sweep flows: 6, 3.5, 3, 2.5, 3, 2, 0, and then 0, and then off ECMO. So a rapid response to somebody who was definitely stuck. Here's another one who we got onto slightly earlier. So again, these are days 3rd of April, 4th of April, 5th of April, 6th, 7th of April, stuck on sweet flow of about 7.5 to 9. Here's the CRP stuck at 250. Here's the ferritin going up through 1,000, 2,000, up through 5,000. And because of the marked hyperferritinemia and the fact that he was treated with methylprednisolone and some anakinra, and he had a dramatic response again. So his CRP falls and his ferritin comes down. He's slightly slower to come off, so we treated him around about the 7th or the 8th, and you can see it wasn't until the sort of the 12th, 13th that his sweet flow falls and he eventually comes off ECMO about a week later. Here's his CT coming through the door. Oddly, it looks a little bit like a normal ARDS, but I think that's probably because he's just collapsed down his bases a bit. But he's got severe disease, and here he is when we saw him in clinic 10 days ago, and his lungs, they're not perfect, but they're pretty good. So, and I think he only desaturated a tiny bit on walking up and down the corridor. So that was a good result for him, given the fact that he was on ECMO for a while. Does it work just on non-ECMO? So here's somebody who's stuck again. So each of these columns is a day. So this takes us from the 24th of March to the 2nd of April. He's sort of CPAP pressure support, but with an FiO2 which is stuck at 50%. And again, a CRP which is stuck at 350, going nowhere despite being bathed in antibiotics. And a ferritin, oh sorry, didn't do the ferritin, but here's the methylprednisolone going in, and you can see a CRP falls. And with that, there's a rapid fall in his FiO2 down to 35, 30, 30, and then down to 28%. And I think he's on air down there, but I can't quite see it because the screen's blocked. And here's the last one on conventional ventilation. So again, BiPAP around about 50 or 40%. So again, stuck for about a week, not really going anywhere. And again, markedly hyperinflammatory with the CRP stuck at 350 despite antibiotics. And here's his CRP responding. So the methylpred went in on the 31st, and you can see the CRP falls. And with that, that's the steroid going in here. You can see rapidly comes off the ventilator on the 28%. So overall, we think they probably do respond, but I mean, that's just anecdote. Here's some initial data. This is the first 10 of our ECMO-dependent COVID patients receiving immunomodulation. They all received methylprednisolone. I think initially this was about 1 milligram per kilogram BD. 2 of them received some anakinra, and you can see there's a significant fall in CRP from being quite hyperinflammatory to less hyperinflammatory, and there's also a fall in the ferritin. And with that, in that group, there was 80% survival, and that's been transmitted. When we last looked last week at 45 completed episodes, we had about a 78% survival. Most of those had immunomodulation.
Thanks, Pete. So this is what we see, and we are simply bedside clinicians describing our experience. We see lots and lots of patients with respiratory failure, and that is a common theme, I think, that all of us share. They don't always look or behave like a typical ARDS, and actually they have features of persistent inflammation. They'll often be flicking fevers, they'll have a persistent CRP, a persistent ferritin, which just is static over days and indeed weeks. And we think we're seeing an organizing pneumonia pattern, both on imaging and pathology. And the other thing that we recognize is obviously their clot potential. We're seeing a lot of clots. So whilst we obviously are fully supportive of the trials, we also have to take a pragmatic approach towards the patients that we are seeing. And this is our experience and our guideline now for these patients. We now screen all of our patients for features of hyperinflammation, and indeed, if they are trial eligible, we put them forward for trials. So the screening for HI consists of these variables, so fevers, and they're often sort of fevers of 38.5 and higher. They can reach up to 41, 41.5. Often the fever chart, the behavioural quality of the fever is quite interesting. It's usually in the early evenings or overnight lesser feature during the day, so a very inflammatory feeling fever in the absence, obviously, of infection, an ongoing or increasing oxygen requirement, and then changes or features of organ insult and metabolic change, as I put here. So the ones we've been talking about, in addition to, for example, triglycerides, fibrinogen, liver function, D-dimers, troponin, and BNP. A significant number, certainly in our experience, have an associated AKI, and cytopenias, whilst they can be a feature, particularly of HLH, in our experience, this tends to be a very late phenomenon. We don't see a lot of it. Our approach to these patients is now, on arrival, they receive intravenous methylprednisolone, so it's a standard Majuri dosing, 1 milligram per kilogram BD for 7 days, milligram per kilogram OD for 7 days, and then actually we've built in a slightly slower taper, so a longer tail to the steroid, so usually 0.5 milligrams per kilogram for 7 days. And what we're aiming for is really tight CRP control. What we want is a normal CRP, or certainly a CRP that is suppressed. If they have an inadequate response, then actually what we do is move towards slightly higher doses of steroids. So then we use pulsed intravenous methylprednisolone at a dose of 1,000 milligrams on a daily basis for 3 consecutive days, then stepping down to the usual maintenance. And we actually now have a low threshold to use anakinra. So dosing that we use is 200 milligrams twice daily, intravenous, for initial 7 days, longer if necessary, just factoring in their AKI and renal replacement needs if required. If they have clear features of a secondary HLH, then we offer them combination therapy, again at the start with intravenous methylprednisolone, 1,000 milligrams, again, daily for 3 consecutive days, followed by the Majuri maintenance and anakinra at the same time. And if we feel that they are adults presenting with the pediatric population, we use the same pulse methylprednisolone and anakinra, but add in intravenous immunoglobulin alongside. We screen and treat for active infection, particularly given the concerns, although actually in our experience, they tolerate the steroid relatively well, particularly with the taper that I think is key. So the screening for infection, as I've said here. And in addition, what we're trying to also do is use their MVALs for COVID-19 at viral loads. And I'm just going to finish on the role of anticoagulation, which, as always, is an interesting issue. And I'll hand over to my colleague, Dr. Retter, for the next talk. And he's just on his way.
Thank you, Nina. Thank you, Boris. I hope you can see me. Just give me a second to load up my talk. Good. So Boris and Nina have introduced me already. My name is Dr. Retter. I'm one of the ECMO consultants. I work in the severe respiratory failure service at Guy's and St Thomas's. I have a particular interest in haematology and intensive care, and have advised in particular on transfusion and hemostatic issues in intensive care. What I want to do is briefly run you through a summary of our activity here, what we think are the important learning points, and then actually really talk to you about macrovascular thrombosis and why I think that's been a problem in COVID, PEs, deep vein thrombosis, line losses, etc., and then microvascular thrombosis, and try and put some context on what we think the potential mechanisms might be and potential ways to go forward. I'm going to rattle through, so please try and stay with me. The first thing I've done is I read this book last year. The surgeon on that book is John Hunter, who was the king's surgeon in the late 17th century. A truly amazing man, and I would recommend the biography to you. And his pattern by which he practiced medicine was to observe, to document, to describe, and generate hypotheses. I very much think that's what we have done here, and we have many more hypotheses to test. The quote there was from when he gave a lecture and was challenged by a student at the end of the lecture to say that it was different to the lecture he'd given the year before. And I'm saying that because this isn't the first lecture I've given on COVID. I'm quite aware that the lectures I gave 8-9 weeks ago, some of the information I'm presenting now is quite different. Indeed, a number of the slides I can take you through shortly are from publications only in the last 3 or 4 days. So it's an extremely evolving field. I'm sure we've all got much more to learn. This is St Thomas's Hospital. We're just over 1,100 bed university associated teaching hospital in the UK. We sit just opposite the Houses of Parliament, and this data was censused on the 18th of May and provided to the Intensive Care National Audit and Research Centre, ICNARC, showing that in our region we've been the busiest in the UK, and our hospital and our local hospitals had seen just over 1,500 patients with COVID. You can see the UK went into lockdown on the 23rd of March, and our peak activity was approximately a week to 2 weeks after that. And at our absolute peak, we had just under 190 patients ventilated with COVID-19 infection. I'm very grateful to Nick Hart for this slide. This is another slide from Professor Hart, and it basically shows the evolution of our survival of our critically ill patients. Up until the 18th of May, we'd had just under 300 patients ventilated in our ITU, and the survival rate for those ventilated patients of just under 70%. Since the middle of March, so not only does St Thomas's support our local district general hospitals, on a national basis, we support, we are part of the Commissioned Severe Respiratory Failure Service. We have a catchment of around 15 million people. It's amazing what COVID has enabled us to implement and change. We have been after an electronic referral system for years. This system was set up, I need to acknowledge my colleague, Dr. Camparotta, for that in the beginning of March this year. So this has only been active, and this graph you can see on the right-hand side of the picture shows data captured from about the second week of March until the 18th of May, when I stopped data for this presentation. What you can see is that 48 hospitals have spoken to us and asked us for advice on the management of COVID patients, multiple hospitals on multiple occasions. This is a really useful tool for us that shows you how extremely busy we've been. And that's not counting the first 2 weeks of March as well, so the numbers are actually higher. We've seen just under 230 referrals. We've managed, as of the 18th of March, 52 patients on ECMO. Actually, it should be 49 patients were retrieved to us. 3 patients, one was retrieved from the Nightingale conventionally and then converted to Vienna venous ECMO within 24 hours. 2 other patients were brought to us from other centres for capacity issues. And that's very much how the ECMO network works in this country. As of that date, 32 patients have been successfully decannulated, giving us an approximate survival rate of 74% at present. And that number will go up and down a little bit as our remaining patients come off. Currently, we have, I'm on call today, as you can see from my scrubs, we've got 7 patients who now remain on ECMO today. I'm sure many of you will be familiar with this, this slide and this editorial that was published in Intensive Care Medicine approximately 4 weeks ago now. Professor Gattinoni is first author, and the last author is again my colleague, Dr. Luigi Camparotta. Very much sort of extolling the principles that Hunter taught. It was about observing and documenting what was going on. And through lots of discussions, this ventilatory protocol was established. I don't want to spend too long discussing this, but what this editorial so succinctly describes is 2 types of phenotypic presentation for COVID pneumonia, and the L phenotype. And by what I mean by that is those patients had low elastance or near normal lung capacity and a normal amount of gas in their lungs, but a low VQ ratio, low lung weight and low recruitability. And it was thought that their hypoxemia was best explained by a loss of regulation of perfusion and loss of hypoxic pulmonary vasoconstriction. And I think that's a really key difference that we've all seen with COVID. This is the ventilatory protocol that we followed. You can see once patients are intubated and deeply sedated, we're happy to ventilate them with up to 8 mils per kilo tidal volume ventilation, because we feel with their preserved lung compliance and with a driving pressure at less than 15 centimeters of water, you're still able to maintain lung protective ventilation with tolerable levels of strain applied to the lungs. You can see we're happy to use prone positioning as well. We were particularly concerned with COVID about the hypoxemia and a potential action of the virus on the pontine pneumotactic center, leading to an increased tidal volume relative to the patient's respiratory rate. we very much felt that tachypnea was an advanced sign of the disease, and we were particularly concerned about the injurious lung injury when patients were spontaneously ventilating. And so that's our approach there. Oh, bear with me a second. There. Many of us use this respiratory mechanics calculator. You can take the web link off there, and we found that extremely useful for working out the theoretical FRC, optimal PEEP, and recruitability of the lungs. Again, Dr. Camperotta has been key in instituting that. And those are just some numbers that from a test that I performed on a patient. As I mentioned, I have a background in haematology, and I'm often called for advice on haematological problems. And my phone was red hot in March and April with people calling me about thrombosis. You can see here a large thrombus in a patient's right pulmonary artery, but also a saddle embolism as well. All our patients who come in on ECMO go through our CT scanner and have a very protocolized set of investigations when they first come in. A part of that is a CT pulmonary angiogram. And we were very concerned about the increase, what we perceived to be an increased rate of thromboses. We were also concerned because many colleagues spoke to us or spoke to me about filters clotting very early, and indeed lines clotting early too. This caused me particular anxiety as since the autumn of last year, due to long-going concerns I'd had for many years over the accuracy of the APTT to monitor anticoagulation on our ECMO patients, I finally managed to bring in an anti-10A monitoring protocol. These are the protocols here. Don't really want you to delve into the details, but for patients on vena-venous ECMO with no evidence of thrombosis, we aim for a 10A level of 0.3 to 0.7. For those patients on venous arterial ECMO, or those patients who are on VV but have evidence of thrombus, we aim for an anti-10A level of 0.6 to 1. Now, for many of you, that might be slightly higher than than you normally target. This shows the nuts and bolts of that protocol there. We have a continuous auditing system in place to see the rate of thrombosis, the coagulation parameters when these patients present, and their risk of bleeding. And this was very much a safety net that we had to put in, or I had to put in, as part of our Drugs and Therapeutics Committee monitoring of this protocol to ensure it worked. This data was actually going to be presented as an abstract at EuroELSO this year. So what did I do here? I compared our historic data, and we've had over 500 patients on ECMO in our institution since we started. And I compared our historic patient populations, not all 500, but so non-COVID patients to patients with COVID. And what did we see? Well, in our patient population, their platelet count was preserved with a median around 220 and quite wide confidence intervals there. Their fibrinogen was staggeringly high in the COVID population. And indeed, we've even seen a fibrinogen of 14, which is the highest I've seen in my entire career. And as has been widely reported, the D-dimers were very high in our COVID patients. You don't need to particularly delve into the statistics, but all those differences are statistically significant. That struck a chord with us due to some previous publications that we'd had. You can see here a publication from one of our former colleagues, Louise Hartley, who's now an ECMO consultant in Aberdeen, showing in just under 300 of our ECMO patients over the last 3 to 4 years, we showed about a 10% rate of pulmonary embolism at presentation. That paper was published last year. Historically, another paper shows about 7.5%. We also showed that there was a slightly higher than expected instance of intracranial hemorrhage when these patients presented. Two of my colleagues, Chris Lockie and Stuart Gillen, both of whom have now gone on to be consultants after they left us, published this paper about 2-3 years ago now, showing approximately a 14% instance of intracranial hemorrhage when patients presented on ECMO. It was again slightly higher. Now, with reference to Hunter, I think I slightly overcalled this initial data. This was a survey I did when we'd seen the first 30 patients, and I included these as pulmonary infarctions. I was concerned at that time that actually there just might be microemboli, which are basically being seeded by large emboli that we couldn't see. I couldn't really put that together. I now think that's wrong. And I think what's much more important is microvascular thrombosis, thrombosis in situ or immunothrombosis, which I'll come on to more in a second. The only caveats I want to put on the increased rate of pulmonary embolism is that we are not very good at screening for venous thromboembolic disease in our critically ill patients. And certainly historic literature, when people have looked more and in more detail, show an incidence of deep vein thrombosis of perhaps 20 to 25%. These patients, as Boris and Nina too alluded already, have been unwell. They have been hyperinflammatory for approximately 11 to 12 days before they end up on ECMO. That's what screening of our first 50 patients has shown. Certainly in the very beginning phases of the disease, there was a tendency to try and treat them with a high PEEP strategy and make sure they were dehydrated. I think that's part of the reason why we have seen more renal failure, perhaps than described in other series, but also dehydrating them, profound inflammatory response, very high fibrinogens, immobile lines is always going to leave you at increased risk of a macrovascular thrombosis. However, based on that data, we changed the advice that we were giving through the severe respiratory failure service and encouraged almost all our referrers to increase patients to therapeutic anticoagulation. Many of these patients were extremely sick. We were very concerned about dead space ventilation, we were very concerned about the dead space because we were continually observing a difference between the end tidal CO2 and PCO2. It's very difficult to move these patients around the hospital because of the infectious risk to other members of staff as well. So on a rather empiric basis, a large number of patients were started on therapeutic anticoagulation. In general, we aim for an APTTR of 2 to 3. If 10A monitoring is available, we use the targets that are evolved. Just going to skip past that one. The other thing I do with our protocol is continuously monitor it. I'd like to call this a heat map. Really, it's an Excel spreadsheet with conditional formatting applied to it. The red lines of 0 are patients who presented with intracranial hemorrhage and therefore they weren't anticoagulated. What this effectively shows is that about 80% of the time, our patient's anticoagulation is in the therapeutic range. We've only had one patient acquire a new pulmonary embolism when we scanned on ECMO, and we've had 4 instances of bleeding in 50 patients so far. 2 were retroperitoneal bleeds, 1 was fatal, 1 was managed with coiling, 1 was a rectal bleed, 1 was an intracerebral bleed. Both intracerebral bleeds occurred with patients on ECMO but off anticoagulation. So this is a CT scan similar to what Boris alluded to earlier. This isn't actually one of our scans. I downloaded it from this website because it gave the best picture of a dual energy CT scan. And this blue area is here with areas of pulmonary infarction. And we were very concerned, and we're going back to look through our CT series to see if we potentially missed areas of pulmonary infarction. And we were really questioning what was happening here to give the preserved lung compliance, but such terrible gas exchange. What I want to suggest to you is that, and as Boris has picked up already on this, it's a very different pathology with COVID-19. As opposed to the classic pneumonia, bronchopneumonia and lobar disease we normally see, COVID-19, I think, is very much a ubiquitous lung problem focused on the type 2 pneumocyte because that expresses the ACE2 receptor. And therefore you get a much more homogeneous involvement or multilobar involvement of the lung. And the other thing, this slide from Lancet Rheumatology paper by Dennis McGonigal shows clearly the proximity between the type 2 pneumocytes, the alveolar cells and the capillaries. This article was published, this Nature medicine or this Nature paper in Knockout Mite confirms that SARS-CoV-2 or COVID-19, the disease, definitely infects us through the ACE2 receptor. Why do we think ACE2 receptors are important? Well, this is a proposed model by Leishman, which was published in Critical Care Medicine, no, I'm lying to you, sorry, in Intensive Care Medicine about 3 to 4 weeks ago now. SARS-CoV comes in, binds to and enters the cell via the ACE2 receptor, infecting the cell and causing a local inflammatory response, as you would expect. There is decreased metabolism of angiotensin II, as its natural receptor has been absorbed, and you get some disordered cytokine release. This leads to shedding of the ACE2 receptor and more conversion of angiotensin to angiotensin 2, and that's a profound inflammatory effect, leading to a positive feedback loop. Promotes leukocyte infiltration, and it's also procoagulant as well. And ultimately, in the latter stages of the disease, illness, as the pneumocytes are dying, the ACE1 receptors are shed, and then there is no conversion of angiotensin 2. Angiotensin 1 activity falls. There is latterly a fall in angiotensin 2 levels, leading to a loss of the vasoconstrictive and autoregulatory effects of angiotensin. And so basically, what this model is suggesting is there is severe loss of regulation of the normal pulmonary vasculature, and I'm certain that's contributing to the dead space ventilation, a profound hypoxia and hypercarbia we were seeing. What this leads us on to is the concept of immunothrombosis. We have an infected alveolus, an infected type 2 pneumocyte here, and disrupted endothelium underneath it. And so what happens is you get a formation of a platelet-rich fibrin plug on the endothelial surface. These platelets become activated, they release microparticles and other granular contents to recruit cells of the immune system. Neutrophils are recruited here. P-selectin is expressed on the endothelial surface, which stops neutrophil rolling and helps recruit it to the surface and the developing area of damage, and that recruits other immune cells too. The neutrophils become activated, and they release their granular contents and their nuclear chromatin, forming neutrophil elastase traps, and that's all part of this immunothrombosis mechanism. And so there are clear linking between platelet and neutrophil action. These recruit other cells, in particular T lymphocytes, to help moderate and control this process and move from an innate to an adaptive immune response. Tissue factors exposed is down here. Coagulation, distinct part of hemostasis, is activated, and the pivotal enzyme in coagulation is thrombin. And you have high thrombin levels, activating more platelets and recruiting more inflammatory cells. Thrombin's anti-inflammatory action is mediated through the protease-activated receptor on the surface of the endothelium here. And this leads to, this excess leads to disruption of this anti-inflammatory effect, and there is further breakdown of further damage to the endothelial barrier. Ultimately, you get vigorous fibrinolytic activity trying to control this process and prevent microthrombi or thromboli in situ forming, and I think that's a large part of where the D-dimers come from. The D-dimers also come from damaged type 2 pneumocytes and infarcted lung. And clearly, I'm saying this is type 2 pneumocyte-centric pathology, infecting a large portion of the lung and a huge vascular bed. We all remember reading West's physiology in the surface area of the tennis court, etc. So we have a huge surface area and a huge area of the body contributing to this pro-inflammatory effect. And I think that's why we're seeing such a prominent acute phase response. Ultimately, this process is overwhelmed and you get microthrombi in situ. Excuse me. This paper came from China about 3 weeks ago. It's in 3 patients, and it shows, it basically looked for markers of NET activation, and it confirmed that neutrophil elastase traps are prominent in this COVID-19 population. There's been a number of post-mortem series now. I'll come on to some of the others in a second. The panel I really wanted to focus on here is panel A, a scanning electron micrograph, which shows viral inclusion bodies in the endothelium. We know they're infecting there. This paper was published released just this weekend by Ackerman in the New England Journal of Medicine. And what can you see here? You can see a microthrombi in situ in the alveolar septa. You also see lymphocyte recruitment here. This next panel is particularly interesting. This is a scanning electron micrograph of the lung microvasculature. This is normal here. This is the lung of a patient with COVID-19, where there is significant destruction to the underlying lung microvasculature, and what they've coined intersusceptive angiogenesis, clearly showing there is damage and activation of the endothelium here. Many of you, like me, probably enjoy the Scott Winecast MCRIT podcast series, and this was a model suggested by Dr. Jalali in one of the most recent episodes last week. I don't agree with everything in the podcast, but I would certainly encourage you all to go and listen to it, as I think it's really, certainly the infographics are amazing. I like this slide in that it's talking about the microthrombi, the shunted blood flow and loss of hypoxic pulmonary vasoconstriction and autoregulation, and that leads to progressive lung damage and parenchymal ischemia and the endothelial epithelial barrier breakdown. I slightly disagree in the podcast in that they talk about capillary vasoconstriction. To me, capillaries don't contain smooth muscle and therefore won't vasoconstrict, but arterioles do. And this post-mortem series from 8 patients in New Orleans clearly shows microthrombi in the pulmonary arterioles. And I'm sure there's a link here based on what I've just told you about the pathology related to the ACE2 receptor and disordered biology of the angiotensin converting enzyme system, and inflammation and disruption of the endothelial barrier causing immunothrombosis. This is a really interesting paper. Again, it's been pre-released from the Journal of the American Association of Cardiology, looking at 2,700 odd patients who were hospitalized and those who received anticoagulation versus those who didn't, suggesting a survival benefit of anticoagulation. That benefit was more marked in approximately 400 patients who were ventilated. That's very reassuring given the huge amount of advice my colleagues and I have given to fully anticoagulate patients. Clearly, I think this paper needs to be, although encouraging, needs to be repeated and studied in more detail, and perhaps more thought. We as a profession need to give more thought as to exactly the best way to treat these microthrombi or this immunothrombosis. So in conclusion, what I wanted to say to you is that about 30% of patients presented with macroscopic venous thromboembolic disease, which is higher than our historical controls, although perhaps not truly massively higher or different from a standard ITU population. Not that picture is uncertain. What I really wanted to emphasize to you was the principle of immunothrombosis and disordered biology surrounding the ACE2 receptor. Interestingly, bleeding and bleeding from pulmonary infarction, even though these patients have been fully anticoagulated, has not been a problem. In our patient series, and I've gone through this in great detail, we are not seeing the coagulopathy that's been described in some of the earlier Chinese papers, particularly a paper by Tang et al. We don't see that. And those who suggested that the patients had an ISTH positive DIC score, we've simply not seen that in our patient population. There definitely might be a potential survival benefit from anticoagulating with heparin. We'd certainly recommend carrying on with that. And I'd certainly recommend using 10A, monitoring anti-10A levels over the APTT. The final slide, you'll be glad it's coming to an end, is I just wanted to say thank you to everybody. You can see that there has been a huge collective effort across the whole country, and particularly in our trust. We've been the busiest trust, or one of the busiest trusts nationally, and that's due to our medical teams, our nursing teams, our allied healthcare professionals, our data support teams, pharmacy teams, hematology teams, laboratory teams. And I just want to say a huge thank you to them, because without their support, none of this would have been possible. Thank you very much.
Thank you, Andrew, and also thank you, Nina and Boris. It's been really exciting, and I would like to point out, as you said, evidence-wise, this is such a fluid situation, and there's so much content that has been gathered by the entire community that really needs to be embraced for this effort. 3 or 4 months ago, none of us would have ever thought of a situation like that, and your input and your contribution today is tremendous. So thank you very much for sharing sharing all of what you went through over those last weeks. I would like to start off with discussing a little bit the first part of this webinar with you on the immunomodulation. As you point out, and as we hear in Europe, is that there are tremendous efforts in the UK to include patients into clinical trials. And when I look at your experience and at your Guys and St. Thomas approach, I very much understand a strong rationale that you gave for administering immunomodulatory therapy, mentioning the cytokine profiles, mentioning the organizing pneumonia, and a large number of cases you have presented today, adding quite some anecdotal evidence that you saw in many patients. Patients just don't improve. Then you start with the immunomodulation at a certain point, and you see things changing, right? Do you at all, with this protocol, enroll patients into studies in your trust?
Yeah.
Or is it the protocol that you have agreed to do on every patient?
So it's Nina here. Peter, thank you for your question. So the guideline that we presented that I showed you at the end is essentially our approach to immunomodulation, really in those patients that aren't active in trials. So whenever they come in, particularly actually whether it's a ward patient or a level 3, or indeed a ward patient that comes to level 3, we have a very active research team that will screen those patients, and we're all aware of the trials that are taking place. If the patients are eligible, then they go into the trial of whatever intervention it may be. And then what we do is we have a fairly close working group in the severe respiratory failure team. So we often will review patients on a day-by-day basis and actually sort of build in that NDT thinking. Now, if, of course, the patients improve and they don't need any additional therapy outside of, obviously, their trial treatment, then what we do is continue them in their active trial arms. If, however, they are in a trial and we are concerned about their progress, or indeed we feel the situation has changed, then again what we do is mobilize the NDT and the research team and think about the individual patients and offer them what we feel is a phenotype-directed approach. So in summary, and in answer to your question, if the patient's trial eligible, they go into a trial. If they are not trial eligible, and of course, so many, particularly of the ECMO patients, are not trial eligible because of the criteria, then we are in a situation where we feel we have to or should offer them what we think is the highest standard of care, and that's really where the guideline kicks in.
Okay, so I mean, you're really into it, and you read all, and you know the literature and what's going on. When do you suppose we will have the first data on interventional trials that tested immunomodulatory approaches that could even further back up your approach? Are there any trials that you have in mind that will come out pretty soon with some data?
So Peter, I can tell you again, it's Nina here, and I'll let my colleagues speak. But just in terms of our trials, the largest international intensive care trial is REMAP-CAP, which you may well have heard of, which is an adaptive trial design with a number of interventions. I think the difficulty sometimes is that actually we're in a fortunate position now where our numbers are falling, and actually, therefore, the question is when the primary endpoints for these trials will be reached. Now, I don't know the answer to that question because I'm not an active clinical trialist. I'm a supportive clinician. But my guess would be that we will not have any initial data for some time to really add to our clinical decision making in the short to medium term.
I just back that up from what Nina's saying. I think the pace of COVID-19 has overwhelmed everybody. The peak has definitely passed in the UK now, and I think almost all these studies now will will require a second peak if they're going to enroll enough patients to ever be completed or reach any sort of significance. And of course, we all hope that we don't see a second peak. So I don't think anyone quite knows what's going to happen, but at the moment, we don't have enough patients now.
Right. But I mean, just again, let me stress that, because that's my general perception of our community when I join all those groups and discussions. It's so much appreciated that you put all the effort in, which will prepare us for some time of the future, maybe a second peak, and certainly quite a long time to go, because this isn't going to go away, even if we may not be so overwhelmed anymore. So this is just a major contribution that you're doing. Now, talking about immunomodulation, we have some quite expectable questions, and I reckon we don't really have the answers, but certainly have perspective on that as far as other approaches are concerned. Talking about cytokine elimination, and in my understanding of the literature, we don't have any trials that show us that in any indications those would impact on any patient relevant outcomes. Do you have experience with that, or do you have a perspective on cytokine elimination systems in this indication?
So I'll speak to that. Nina might want to add a comment in a second. I think as a specialty and as a collective, we've got an obligation now to define what a cytokine storm is. There's lots, all the slides that we put up, there's markers going up and down everywhere, but we need to try and define what we view as a consistent panel, what the ranges are in those, and so we can better target our disease. I'm not sure that the cytokine levels we see here are the same as the cytokine storm you see in patients with CAR T-cell therapy, etc. And I think it's really important that we just do some basic science to tease out those studies, and that will enable us to target our immunomodulatory therapies better, because clearly they're important in this disease. Nina.
Yeah, no, Peter, just to say that I think it's difficult. This is a condition, as I mentioned before, that is marked by heterogeneity, and I think phenotyping these patients is key. Not just at single time points, actually, longitudinally as well, in terms of their disease behavior. And I think it's only by doing that and trying to phenotype them both clinically, radiologically, immunologically, response to therapy, for example, that we're going to find that individual therapies work for individual patients with individual specific phenotypes. That's my own thinking as a clinician, again, at the bedside. I'm not sure that it's going to be one therapy that is going to treat everyone that is infected by SARS-CoV-2. I think actually targeting treatment to individual patients at individual times, i.e. that personalized approach to therapy, is going to be key, and we'll only get there with phenotyping, I think.
If your question was specifically about the columns, and also with regards to netosis, we are particularly interested, and that's something we'll look at going forward, although it'll probably take us longer than we would like before we get hold of the columns.
Right. I have two more things that came in, questions about the protocol, which I think are very important. You mentioned that you look for and also screen, and then if you find that, treat secondary infections. Now, looking at the numbers that you have treated with that immunomodulatory approach, secondary infections, is that something that you see in large numbers? Are there any feelings or evidence already?
So we try desperately to be consistent, and we're incredibly lucky to be supported by the teams we've got around us. So for the ECMO patients, there's very much an admission protocol. And then for all the patients in the hospital, the critical care team provided a routine order set of bloods, so routine inflammatory markers, and that's been adapted as we've gone through the COVID process to create a huge amount of data. I can't really talk to it because the data hasn't yet been analysed. You can imagine we're doing a lot and looking through these COVID patients. So there's 53 we've got now. Most of the data I showed you was on the first 50. I've also got a table with only 42 patients filled in with their microbiology. And it looks that there is some risk of, as you would expect with what we're using, of secondary infection. Now, I'd put some caveats on that. That requires a number of us to go through that data and agree that it's a secondary infection. Normally, the ECMO unit has 11 beds on it. To cope with the surge, one of our nurses, who's absolutely brilliant, suggested that we use 1 pendant per patient. So in peak surge, and the bits you saw there, we had 20 patients in our 11-bedded unit. And clearly, with all the PPE and all the other PPE issues, maintaining what we would view as standard infection control practice was difficult too. So it was a tremendously difficult time at peak surge. And so that's an infector there. What I will say, though, is that we haven't had any patient die of a secondary infection that we can see. We've had, normally we've got a low threshold to change lines if we see a flick in a CRP or any evidence there might be a line change. Given the huge volume of work we were doing, perhaps we were a little bit delayed on 1 or 2 occasions. There was one episode of possibly transmission of an organism from one bed space to the next. But I think that's predominantly explainable by the environment we were in rather than specifically the immunomodulation approach we were using.
Peter, I'm just going to add to that, if I may. So the other signature dishes that Boris and I offer to our severe respiratory failure team are the vasculitis patients and those that present with a rapidly progressive interstitial lung disease in association, for example, with a ILD. And what I am noticing, and I think this again is something to note, is in those patients we use big doses of steroids, we use big doses of cyclophosphamide, we use combination immunosuppression, and I say suppression as opposed to immunomodulation, which I think is an important aspect to COVID-19 and hyperinflammation. And actually, even in those patients, we don't see a sort of a strong signal of intercurrent infection. Using the Majuri dosing of steroids with anakinra, which is a really clean, safe drug with an established track record, particularly with a view to adverse events, we are not seeing lots of what we think is treatment-related morbidity, i.e. intercurrent infections due to their immunomodulation. Now, that's my feeling. I can only tell you again what we're seeing from our practice, but we're not seeing high rates of intercurrent infection. And I think it just goes back to it's how you use your drugs, when, at what dose, and for how long, and actually you taper them once you've achieved your therapeutic effect. And that way around, I think you're likely to limit the treatment-related morbidity and maximize the efficacy of these agents.
Okay. Maybe a last question on that topic. Do you at all, for any indication or for any risk profile, patients use prophylaxis? Let's give you an example. For example, we know that up to 25% of flu patients on ECMO will come down with any kind of aspergillus problem. Yeah. Do you cover anything prophylactically?
So we don't tend to give prophylaxis. However, all the patients have a bronchoscopy and admission, BAL and galactomannan sent, and there'll be serial galactomannan sent as well. We've got a very, I'm aware of the paper, we're all aware of the SRF service monitors that really closely. We've also seen some aspergillus in our post-mortem series. So we've got a very low threshold if we're concerned for infections to repeat bronch, repeat BAL, and look for fungus and escalate to treatment at that point. The point I put back to you about prophylaxis in ECMO is what dose would you give? We know we have problems with voriconazole levels. We're worried about renal function with ambisome, etc. There's also some concerns about aninsular fungin levels. So I'm not sure that prophylactic doses that we would normally give would actually work. I guess my answer is I don't know, but we don't routinely give antifungal prophylaxis, but I've got a very low threshold to look for it.
Okay, that's clear. Now, I would like to spend the last couple of minutes discussing some of the coagulation issues that you've raised. Well, first of all, I think you gave a very clear talk and you have a very clear approach in your center on how to deal with it. And I was happy to see your numbers that you presented, that you didn't really have a massive issue with bleeding, and that you only see one pulmonary embolism with this kind of...
That's acquired on ECMO. Yeah, no, we haven't seen many. We routinely screen patients for thromboses when we decannulate them.
Yes.
We don't. So what are the points I would make there? We make sure we screen both femoral veins. We've also started to include scanning people's inferior vena cava, as prior to COVID starting, we'd seen one or two cast-like thromboses in the inferior vena cava. There's just the sort of pre-COVID rate of infection of deep vein thrombosis was approximately 20%. We've only got 30 patients off so far. It looks like about the similar sort of rate of deep vein thrombosis is in that population. The numbers are a bit too small, and we need a bit more time to get a clearer picture there. But importantly, in terms of a new acquired pulmonary embolism, which affected the gas exchange, it's only 1 in the 50 so far.
Okay. Now, what's your protocol say about anticoagulation after cannula removal?
Okay, so what we would do is we would restart the anticoagulation. So it depends, first of all, if the patient's got a known pulmonary embolism or large thrombus, they will need ongoing anticoagulation. And so we tend to stop the heparin for 2 to 3 hours before they're decannulated. The patient's decannulated, sutures in place, and we wait 3 to 4, well, somewhere between 4 to 6 hours to make sure there's no bleeding, and then restart. We hope to have an ultrasound on the same day. That isn't always possible, and it's often done the next day. And so we will look. If the patient doesn't have a deep vein thrombosis the next day, they'll step back down to standard thromboprophylaxis, which is about 5,000 units of heparin, of subcut low molecular weight heparin once a day. For COVID patients, in particular in light of their high fibrinogen levels, we've been giving what we'd call intermediate dose thromboprophylaxis. So that'd be 7,500 units once a day for those patients. And then we would step that down to 5,000 units when they went to the ward. There's an argument about giving extended dose thromboprophylaxis. We've kind of left that decision to the ward at the moment, although some of our colleagues have suggested giving patients 10 milligrams of rivaroxaban or low molecular weight heparin for 2 weeks as extended thromboprophylaxis when they go home. That's our policy.
Right. So given the rationale that you presented and the data that is around from clinical data, at least emotionally, that makes a lot of sense to me. And actually, this is how we approach it in my center. Any ideas on targeting the thrombocytes therapeutically in these patients?
So I'm particularly interested in thrombin as a key molecule for these microthrombi in situ in the lungs. I wouldn't want to do it out with the context of a clinical trial, but I think there's a lot of rationale for considering a direct thrombin inhibitor, either argatroban or bivalirudin. The reason I say about doing it in the context of a clinical trial, what you haven't seen as part of the presentation is it was about 8 months worth of negotiation for us as a trust to decide the anti-10A testing kit that we used for lots of factors. But we use a kit which doesn't have exogenous antithrombin added to it. And that was my decision with our previous lab manager, because we felt that gives the most accurate picture of anticoagulation on ECMO. We measure everyone's antithrombin level when they come in and supplement it. And a lot of work went into that lab test. The APTTR, the activated partial thromboplastin time, just simply, in my opinion, isn't accurate enough for monitoring anticoagulation in these patients. And if you're going to measure argatroban and bivalirudin, it still wouldn't be accurate there. And I'd be really worried about the risk of bleeding or both over and underdosing those agents. I know that we've got a 2A assay in our lab, and that one of the jobs for the first 6 months of this year was to get that up and running. I'm sure, as you can imagine, that has not happened yet. It's something hopefully we can do later in the year, and we've got a particular interest there. There are some old papers, paper from 2005, doing serial BALs in patients who were ventilated. And if patients were ventilated with a 0 PEEP strategy, I mean, clearly that's not something we do now, but had 10 to 12 mils per kilo tidal volume ventilation, BALs of their lungs showed an increased concentration of thrombin. And you just wonder if these patients have not got lung protective ventilation, or they've got spontaneously ventilating with very large tidal volumes, if that is also giving a pro-inflammatory or thrombin signal to the lungs too, and facilitating the formation of microthrombi in situ. That's something we're really interested in and may well go on to look at in due course.
Okay, I have 2 last quick questions. The one is, do you have experience with like any sort of viscoelastic coagulation testing in these patients?
Secretly, we've done a few. We don't normally use TEG in ECMO, although we do have access to a TEG6 machine, and I think it's very interesting. I think a couple of things we take. If I take you back to this slide, I'm a little concerned about our anticoagulation when they first come in. So our protocol doesn't give you a bolus dose, and I think there's a role for using TEG here to see if we should give a bolus dose or not once we've got a CT head that doesn't show they've got an intracranial hemorrhage. Mm-hmm. The point I would challenge you on thromboelastography is that it shows you what you're expecting. These patients have got a hyperinflammatory response, a profound acute phase response, a really high fibrinogen, or a preserved platelet count. So your R time's short, your alpha angle's large, and your maximum amplitude is high, which is what you're expecting. Sort of using TEG in the reverse way to which it was engineered, instead of giving targeted blood support to anticoagulate, I don't have enough experience or competence to do that yet. And I'm not sure for me, if I looked at a patient with a high maximum amplitude, I'd want to increase the intensity of their anticoagulation. A 10A level of 0.8 to 1 is high. And although we haven't seen bleeding, I really wouldn't want to push it beyond that. And obviously the circuit itself is anticoagulant in some way.
Okay, and the last open question, and then Boris has shown a lot of courses what happens if you give the immunomodulation, and I really like the wording of immunothrombosis. Have you looked into the courses of coagulation activation markers after you initiate immunomodulatory therapy? Did you see any effects, or did you have the time to go into that yet?
So we haven't. So before COVID started, I was doing a study specifically looking at alteration or disturbances to coagulation in ECMO. Those are research tests that we're doing and research samples that had to be taken. All that research had to be stopped when COVID started. We've now got approval to restart it again and see if there's a difference between non-COVID and COVID patients. It's just we've not had a COVID patient for the last 3 days since I was able to reopen that study. But well, hopefully we don't see any more COVID patients. If we do and they go on to ECMO, we'll desperately try to enroll them and see how their coagulation parameters change. Particularly interested in disordered fibrinolysis. I think there's a real signal to that in the COVID population. One of the other things we've thought about is that if you look at these patients that have really high factor VIII levels, really high von Willebrand factor levels, I don't know what their ADAMTS13, their von Willebrand factor cleaving protease is, but you might have a relative deficiency. If you've got a factor VIII level of 800, let's say 100 is normal, but your von Willebrand factor is 6 to 8 times normal as well, but your vulnerability cleaving protease is relatively low or doesn't go up by the same amount. And von Willebrand's is a key molecule in terms of anchoring the platelets to the endothelium. And I just wonder what's happening there. That was a theoretical discussion with a friend a few days ago, but that's absolutely something that we're looking at. Thank you.
Okay. Well, one final request. Can we see all of you again to say goodbye? Well, on personally and behalf of EuroELSO, I would really like to thank for preparing this and for giving your time. It's been so valuable, especially considering your circumstances. Thank you so much. And thank you for our audience to joining us today. I would like to announce that probably around the end of June, there will be some more massive offers of EuroELSO on the topic of COVID, like something like a virtual ECMO day that can be joined for free, and it's quite a massive session, and you will be informed in soon by email and by all of the social media channels. And obviously, you probably will have heard that fortunately we have not been struck as hard here in Vienna, but there's one last good news from here as well. We've been treating a patient on ECMO for several weeks, and the lung clearly was destroyed. There was no hope that she could discover. And in my understanding, she was the first one in Europe who underwent successful double lung transplant last week, and just in intensive care and recovering right now.
Fabulous.
So far, I'm very humbled to be part of a very great and multidisciplinary, multi-professional team to take care of such patients in such situations. Now with this, I would like to remind all of you, if you do ECMO, you're only safe if your venous line is blueberry and your arterial line's cherryberry. Please stay all safe. Stay with EuroELSO. Have a look at our social media channels continuously, more or less. And I'm very happy to welcome you back next time. Goodbye for today. Thank you.
Take care. Thank you.